BRAF wild-type melanoma, which is currently very limited therapeutic option available for. So Australia is such a beautiful country. We have the most gorgeous weather in the world, high sun exposure, which is just lovely, except we also have the highest rates of melanoma in the world. And the rates have even doubled over the last 20 years. The rates of melanoma are still on the rise, with an estimated 392 extra cases per year, and over 1,500 people die of melanoma each year in Australia. 1 in 17 Australians will be diagnosed with melanoma before the age of 85, and this is due to the extremely high UV index that we experience in this country. So I'll start by giving a bit of background about melanoma pathogenesis and the deregulated pathways in melanoma. There's 2 main pathways that are deregulated. This is the MAPK pathway here and the PI3 kinase pathway. Melanoma typically harbours 2 broad classes of mutation. There's activating mutations in the BRAF protein, which account for about 50% of melanomas, and about 15 to 20% of melanomas have activating mutations in the NRAS protein, and these mutations are mutually exclusive. Patients that harbour mutations in BRAF will also experience deregulation of this PI3 kinase pathway by loss of either PTM or gene amplification of AKT3. So a bit of background about how we came across our particular compound. Like much of research, we actually came across this compound while we were looking for something else. So we initially did a screen of over 10,000 compounds looking for enhancers of the HDAC inhibitor SAHA, and this was done in MDA breast cancer cells. From this screen, we identified 21 candidate compounds, and 7 of these were validated. When we went to test to see if these compounds were enhancers of SAHA in melanoma, we didn't find that they did enhance SAHA in this particular cancer type. But we did find a number of compounds that had single-agent activity in melanoma, which was quite interesting of itself. We identified 1 compound, which is known as compound 12, which had the highest efficacy from our single-agent active compounds. So what we've done is we've screened compound 12 across a range of cell lines, and we wanted to know, well, is this compound specific to melanoma, or is it targeting cancers in general? Is it targeting normal tissues? And what specificity does this compound have? So we screened it across normal fibroblasts, a panel of adult cancers ranging from ovarian through to liver cancer, a couple of neural crest lines. So melanoma is of a neural crest lineage, so these could have been potentially targeted by our compounds. We assessed normal melanocytes and also a range of melanoma cell lines. And what we noticed was our compound seems to prefer targeting p53 wild-type melanoma. And this initially was quite interesting, except that the majority of melanomas have p53 wild-type, and over 90% of melanomas are wild-type for p53. So we didn't think this was too significant. What we did want to know was, could our compound actually synergize with other anti-melanoma treatments? So melanoma is a cancer type where a single therapy is not enough to really target the cancer. A combination therapy is required. So we tested our compound in combination with either dacarbazine, which is the previous standard of care in melanoma, and vemurafenib, which is a targeted compound which is specific to BRAF mutant melanoma. And our results were quite interesting. What we found was our combination of compound 12 and synergizes with vemurafenib, but what it targets preferentially is the BRAF wild-type melanoma cells. So these cells are a cell type that vemurafenib is not targeting as a single agent, and it's not used clinically for the treatment of these melanomas because it can actually enhance cell growth. We did this over a range of BRAF wild-type cell lines and also BRAF mutants. And when we performed synergy studies, we saw a mixed response in the mutant lines, with some showing a combination index less than 1 denoting synergy. But every wild-type line we tested was synergistic, and we also have more supporting data of wild-type lines aside from those two. When we looked at clonogenicity studies, we did this by looking at the colony-forming assay. And this is because melanoma is such a highly metastatic disease, and its ability to form colonies and establish new tumours is a characteristic of why it's such an aggressive malignancy. So this colony-forming assay was done using either the DMSO control, compound 12 is a single agent, vemurafenib is a single agent, and the combination treatment. And this is represented here in the BRAF wild-type line. And what you can see is the combination treatment actually ablates colony-forming ability. Again, this was done over a range of melanoma cell lines, and the wild-type line showed a clear decrease in colony-forming ability, except for one line which was resistant, but also the mutant lines showed a decrease in colony-forming ability with the combination treatment, again, except for one resistant line. So we asked ourselves, what is in these resistant lines that may confer their resistance to this combination treatment? So our lab is interested in a protein called TRIM16. We've previously worked on this in melanoma and published this work last year to show that TRIM16 is actually decreased during melanomagenesis. And in terms of patient prognosis, high TRIM16 is associated with or correlated with favourable prognosis, with a median patient survival of 59 months, compared to a low expression of TRIM16, which has a median patient survival of 16 months. And you can see high TRIM16 is represented on the left-hand side here, low TRIM16 is represented on the right, and this is for a cohort of 170 stage 3 patients. So while we were looking at those two main pathways in melanoma to see if our drug combination affects those pathways, we also looked at TRIM16 protein expression to see if that was being affected. And what we found was that TRIM16 protein expression was increased with the combination treatment in all of the BRAF wild-type lines that we tested, which is shown by Western blotting on the left-hand side here. This was quite striking, and the level of reactivation was actually very strong, but we didn't know whether or not this was functionally relevant. So we used specific siRNAs to target TRIM16 to see if it was functionally important for the decrease in cell viability that we see with the combination treatment. And when we use these specific siRNAs, we actually lose this phenotype of decreased or reduced cell viability. And this suggests that TRIM16 is at least partially required for this combination mechanism of action. Represented down the bottom here is the Western blot of TRIM16, showing TRIM16 activation in the control and a decrease in viability, and then loss of TRIM16 with the use of siRNAs showing an increase in cell viability. But we didn't want to be too biased in our approach and just focus on our particular protein that we were interested in. So we also performed a microarray study looking at deregulated pathways associated with drug combination treatment. And what we found was with combination treatment, we found a number of genes in the pathway of cholesterol biosynthesis were increased, which we hypothesized could be due to a decrease in cholesterol or a targeting of cholesterol, resulting in a transcriptome of cholesterol biosynthesis. So when we looked a bit closer at cholesterol, we measured cholesterol localization in the cell by Philippine staining, which is a measure of free cholesterol in the cell, with increasing doses of compound 12. And what we see here, compared to control, is an aggregation of cholesterol in the cell, suggesting that compound 12 is impacting cholesterol movement within the cell. When we also looked at particular biomarkers of cholesterol biosynthesis, LAP1 and MPC1, which are localized in the late endosome stage of cholesterol biosynthesis. Compared to control, we also used a known cholesterol inhibitor, which is U18, which is known to interrupt the transport of cholesterol to the endoplasmic reticulum. And we notice here that compared to control, compound 12 is acting in a similar manner to a known cholesterol inhibitor, by impacting cholesterol trafficking. This is a schematic just showing that cholesterol trafficking, where we've got cholesterol entry into the cell, being packaged into endosomes and going through a transport system towards the endoplasmic reticulum. U18 blocks the transport of cholesterol from the late endosomes, and compound 12 is acting in a similar manner to U18. And additionally, lovastatin, which is the most common cholesterol inhibitor prescribed, which targets HMG-CoA reductase and also blocks cholesterol biosynthesis. And we wanted to know, or to test, if compound 12 is acting as a general cholesterol inhibitor. To do this, we used some synergy studies using a combination of lovastatin and bimoraphenib. So we wanted to ask the question, if our compound 12 is a cholesterol inhibitor, do actual cholesterol inhibitors synergize with bimoraphenib? And if they do, could this be a potential treatment for metastatic melanoma? So cholesterol inhibitors have the advantage of being extremely well tolerated by patients, being able to be given at high doses. So when we performed the synergy study, this is in the same format as the previous synergy work that we've done. You can see that at optimal dosing, we have a decrease in cell viability with combination treatments. In both, these are two representative lines shown here, both BRAF wild type. And when we performed the synergy study, you can see that the combination index denoting synergy is less than 1, showing a synergistic profile with the combination of these two agents. So that potentially suggests that cholesterol may have application towards treatment of BRAF wild-type melanoma. We wanted to go on to actually test the in vivo efficacy of our drugs. So we performed a microsomal stability assay of our compound 12 to see how stable it is with liver microsomes, to see if an oral route of administration would be suitable for testing this compound. What we found was the microsomal stability gave a half-life measured by mass spec of only 13.5 minutes, which is quite short. We were aiming hopefully for around 45 to 60 minutes, which would be reasonably stable. We decided we wouldn't administer this orally when we did our mouse studies, but we instead performed an IV, and we measured the half-life of our compound 12 administered as a bolus dose of 5 mg per kg, and we found it had a half-life of 70 minutes, which was quite favourable in the plasma, so we proceeded with that. We then went on to do maximum tolerated dose studies, where we did a dose-up profile ranging from 5 to 20 mg per kg. We determined the maximum tolerated dose to be 20 mg per kg with an acceptable dose of 15 mg per kg. So when we did the xenograft model, we utilised our MelJD cells, which the bulk of this in vitro work has been performed in, to perform the xenograft. So these were engrafted into biopsy nude mice, and the tumour was allowed to reach a particular volume before commencing treatment. The treatment dose was 5 days on, 2 days off to mimic the clinical application of therapy. And the control is represented here in black, where we see a clear increase in proliferation of the melanoma cells over time. Compound 12 as a single agent showed a degree of efficacy, or a limited degree of efficacy. And bimoraphenib as a single agent actually showed a promotion of growth, and this is something that's known clinically because these are BRAF wild-type cells, they're not responsive to bimoraphenib, and you actually can see a growth when bimoraphenib is applied. But interestingly, the combination treatment actually showed a significant decrease in tumour volume. This was actually quite encouraging, where we saw after 5 days treatment a decrease in the tumour volume, which may indicate that the compound is actually quite effective in vivo. But very soon after, we saw an increase in proliferation again, and this is possibly due to the nature of melanoma. Being such an evolving malignancy, it overcomes drugs quite rapidly. But this was initially encouraging as a first study of this combination, just to see if we had in vivo efficacy, and it looks like we have a positive result to work from. We also looked at the level of TRIM16 protein expression at the time of harvest of the tumour to see if we could reactivate our TRIM16 Trin16 protein, and that may give us further evidence that our compound 12 is targeting the tumour. Unfortunately, at the time point that we harvested the tumours, we didn't see any change in Trin16, although we may have harvested the tumour too late to actually see that reactivation, as the tumour may have actually overcome that mechanism. So to summarise this work, we've identified a new compound, compound 12, that works in synergy with vemurafenib, but it preferentially targets the BRAF wild-type cells, which was unexpected, but we think we have some idea of the mechanism as to why this might be. It partially requires a reactivation of Trin16 for its synergistic mechanism of action. We've also identified that compound 12 may act as a cholesterol inhibitor, and after that work we've shown that cholesterol inhibitors also synergise with vemurafenib, and they may offer a novel therapeutic approach for the treatment of patients lacking the BRAF mutation. And combination of compound 12 and vemurafenib shows in vivo efficacy against BRAF wild-type melanoma and xenograft model. With that, I'd like to thank the people involved in this work, the supervisors of this work, Dr. Valerie Chilling and Professor Glenn Marshall, various members of the molecular carcinogenesis program showed here, and our collaborators, Professor Grant MacArthur, who's a leader in melanoma research down at PNMAC, and collaborators Professor Shudong Wang and Zidong Zhang for intellectual input into this work. Thank you.
Thank you very much. Thank you very much, Dr. Sutton, for the interesting subject. If you have any questions or comments, please go.
If you think you're targeting cholesterol, did you try simvastatin or samstatin next door to your?
We did. We tried simvastatin as well as alongside lovastatin, and also the other cholesterol inhibitor, which was the U18, and we showed synergy with vemurafenib in all of those statins.
No, with your compound.
With our compound,
Very
together with our compound. Why would we do that?
Just because it's another line of evidence that this is the mechanism.
If we think our compound's a cholesterol inhibitor, I wouldn't think we'd pair it with another.
It wouldn't synergize, and that's another level of evidence that this is the mechanism.
We decided not to do that. I'm not sure the rationale for that would be that strong, because I don't know what it would show. It would just show it doesn't synergize. I think the synergy between cholesterol inhibitors and vemurafenib is a stronger evidence from what we know that.
No, it's not your work. It's not. You want your work, your 12 compound.
Yes, we do. Yeah. So we can do other studies to see how closely it's acting as a cholesterol inhibitor, and to try and refine the mechanism a bit further.